From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Hello, and welcome to our listeners around the world. You're listening to JAMA Ophthalmology Author Interviews. Thank you for joining us. I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology. Today, we're going to look at assessment of blood pressure in ophthalmology clinics for patients who have diabetes. This was undertaken at the University of Virginia's Department of Ophthalmology in Charlottesville, Virginia, and at the Virginia Commonwealth University School of Medicine. Joining me to discuss this publication is the author of an invited commentary that accompanied this original investigation, Dr. Rishi Singh. Dr. Singh is the chair of the Department of Ophthalmology at Harvard Medical School, which includes the Massachusetts Eye and Ear Infirmary and Mass General Brigham in Boston, Massachusetts. Rishi, thank you so much for joining us.
It's a pleasure to be here, Neil.
So, Dr. Singh, this was a single center case series, but it really caught a lot of attention of the editors because the authors reported that uncontrolled or previously unrecognized hypertension was highly prevalent among patients with diabetes, even those who indicated they engaged in routine medical follow-up. Was that your interpretation of their findings?
Well, I think the canary in the coal mine is seeing this significant patient population, which comes to doctors regularly, gets blood pressure medication, and really only 1 in 12 had normal blood pressure. And I don't think it's an access to care problem. I think it's the control, which really isn't happening often enough. And we all know that this is the view of the retina, which is a window to many things. I think in years to come, Neil, we're going to see our field focus on the state of oculomics and what that might mean for our field. We'll be able to pick up systemic disease in many different realms. But in the most basic sense, in an integrated health system or even in a private office, you can imagine that this is a setting for potentially other risk factors like myocardial infarction, stroke with uncontrolled hypertension. And it is a very well done study overall. I have to say, this is a population we take care of a lot. And I think that there's a lot of value to at least highlighting the issue, not to necessarily prescribe anything from it, but just certainly to highlight the issue and then to determine what the next steps might be in regards to the future of the care we provide.
So one of the obvious things people think about is, should I be measuring blood pressure in my patients' clinics?
Yeah, that's a great question. I think that we all know that this is a pitfall issue. If you're not trained very well, it's possible if you get erroneous values and the wrong values. I think the other part of this is really the fact that even if you were skilled enough to take the blood pressures, there has to be a protocol that needs to be developed in order to escalate those patients who are in the most need. That's not something the article necessarily describes, but if you have a patient who is in stage 2 hypertension or even hypertensive crisis or even hypertensive urgency, those are things that much of the retina community don't necessarily know the factors and stages of. And I think that that's an area that we could potentially develop over time because there has to be sort of a standardized protocol by which we handle these patients. Otherwise, we're going to refer patients inappropriately or probably to the wrong site locations. And that's really about the escalation, the documentation, and to really help our other colleagues managing these patients ultimately downstream.
Some of our colleagues actually do measure patients' blood pressure when they come to clinic. I don't think it's a majority right now. Is that something you've done in the hospital systems that you've experienced?
Yeah, it's interesting. So in Mass Eye and Ear in Boston, we actually do measure blood pressure in some of our clinics. Those are the hospital-based clinics where there are nurses actually involved in the care of the patients. Those are high-volume injection clinics where the nurses are really a part and parcel of that care continuity. In the clinics that are typically our outpatient practices, which are non-hospital based, we don't have those nurses there, so that it's not measured reliably. Something like this, though, this study points out the value and benefit of potentially doing this across the board. Again, with the proper guardrails installed, it could be just one more metric we're providing that outpatient provider who's in endocrinology or primary care or nephrology, who's waiting on some information. And we all know that when patients come in, they may not always make every one of their appointments. The number of patients who have diabetes and don't show up to their appointments, we've done this study before, it's close to 20 or 30% don't show up for their appointments on a regular basis. This, again, is an opportunity for us to just increase that net by which we may see them in practice.
And one of the things that was notable was that some of these blood pressures were potentially way out of control. And if someone's in a clinic like that, let's say these hospital-based clinics where you said perhaps it was part of the routine or required to be a hospital-based clinic, what do you recommend people might do if they find such very high levels? Do they go to the emergency room? Do they just get a phone call to their internist? How might the ophthalmologist listening to this address those things?
I think that this speaks to the larger potential opportunity. I think as a community of ophthalmologists, we could work across specialties, the Academy and maybe the American Heart Association or the ADA to kind of develop those standards for what we could do with our patient populations. I think this is where we need our primary care colleagues or our cardiology colleagues to weigh in on this. Hypertension that is at that level of hypertensive crisis most certainly causes nephropathy and downstream effects in those patient populations over a longer term. I think the idea that we care coordinate with them and continue the continuity of care has been well established by many of our insurance providers. Even this year, as you're aware, we had a new code added to our system that really remunerates physicians for chronic medical conditions, hypertension being one of them. So there is an opportunity to work with both our colleagues across the aisle and sort of learn what those protocols need to be. But certainly you don't want them to all go to the emergency room. Hypertensive emergency is well defined by American Heart Association guidelines. I'm quite familiar from that from my last role and as a chief medical officer of a hospital system. And so there's certain patients you definitely need to see in practice, and there's certain ones you need to see in an urgent care setting or even an ED setting. And that really would be determined by these protocols that I think we can develop as the AAO and others may work together on those sort of opportunities. I think at this point it's too premature to recommend that.
And talking about premature, do you think we can generalize the magnitude of these findings to other clinics, or should we keep in mind that this is just one particular hospital at one particular point in time?
Well, I think directionally it's probably correct. Whether the true number is close to 1 in 12, which I think was the results of this paper, versus being closer to 1 in 8, I don't know if that really helps us necessarily, but directionally it's probably very, very true. The biggest challenge we're all facing, as you're quite aware, Neil, is Medicaid redetermination is coming across the United States. That's leaving patients with care gaps. There's obviously a large population of uninsured and even patients from other countries who are not citizens of the United States who are living with us and they don't have insurance. If you look at this somewhere in the middle, these are insured patients obviously able to come to clinics potentially, versus those larger populations of people we didn't even assess, or even the well cared for population who's well insured. So I suspect this is directionally correct from what we see, but we probably have a large amplitude of patients above and below this percentage point when you look at the totality.
And a lot of times I speak to some of our internists who perhaps laugh at the way we measure blood pressure without any concern for are they sitting, are they standing, are their legs crossed, just like we may not approve of how they measure visual acuity. Would we have to begin to learn how to take blood pressure if we were going to do this, or are there automated ways of doing that now that get away from sort of the variability?
Yeah, actually, that has been a great advancement in the field. And it's really this determination of 3 blood pressures in a row, which has really been the change factor in blood pressure management for many years now. Many of the patients also can have white coat syndrome when they walk in the door, and they can have some effect on blood pressure alone. But this serial measurement of blood pressures has really become the standard of care across primary care and other specialties now. And even home monitoring has added to this as well. So we would have to learn, but I think the answer is machinery has improved drastically. It's not the typical take out the stethoscope, take out the blood pressure cuff. Cuff size does matter. So again, that would be another thing to figure out in these patients as far as determining whether you use the proper cuff size and what the orientation needs to be. But I think for the most part, these devices have gotten easier, and the serial blood pressure measurements have been quite a huge advancement in our understanding of hypertension. So that can be very, very easily taught to many of us. So it's getting easier for the most part, but I think we need to set the standards for it across the board.
And finally, you mentioned that term oculomics. Walk me through that. What does that mean? That we look at the vessels on a fundus photograph and we can determine who's at risk for cardiovascular disease? Or what is that catch-all phrase that is now falling into so many investigations that we hear about?
Yeah, so it's a broad term. It refers to not only looking at the patient's kind of local factors, but what they might relate to in the systemic circulation. So, for example, at the local level, we know from people like Google DeepMind and others that you can actually look at a fundus photograph and determine from that whether a patient is a female or a male at this given stage. That's a huge advancement in our field, just looking at vascular morphology and determining that from that perspective. In addition, we now know that when you look at the earliest stages of things like Alzheimer's and even Parkinsonian diseases, we're learning about how advancements in OCT and OCT angiography, as well as looking at structural OCT in general, has added to the ability of picking up some of those conditions over time and predicting those conditions over time. And the last piece, I think, that has been one that I've personally had an experience with and worked on is around the cardiovascular risk factors. There's a very well-known risk factor called LPA that's been around for a couple of years now. And we're learning about how this cardiovascular risk factor can be associated with some of the retinal findings in patients. And so that would be a way of measuring some of the cardiovascular risk associated with some of those ocular risks or ocular changes we're seeing, hence staging a patient appropriately for the future.
Well, we really appreciate your expertise. Thank you so much for sharing your experiences and your insight on this very important commentary. I've been speaking with Dr. Rishi Singh at the Massachusetts Eye and Ear Infirmary. Rishi, thank you so much.
Thank you for having me, Neil.
I'm Neil Bressler, and I've been speaking with Dr. Rishi Singh, the chair of the Department of Ophthalmology at the Massachusetts Eye and Ear Infirmary of Harvard Medical School, on the assessment of blood pressure in ophthalmology clinics for patients with diabetes, where the authors found that uncontrolled or previously unrecognized hypertension was highly prevalent among patients with diabetes, even among those who indicated that they engaged in routine medical follow-up. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thank you, everyone, for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.